Welcome to Stanford Medicine and to the Stanford Radiology YouTube video channel.
Hi, my name is Jody Shen, and I'll be reviewing blunt traumatic aortic injury for the radiologist. After reviewing this video, participants will be able to describe the mechanism and patterns of blunt traumatic aortic injury, or BTAI, understand the definition, classification, and management implications, and recognize normal appearance and complications post-repair. Here are some QR code links to suggested reading for background. First, it's important to discuss the mechanism of blunt traumatic aortic injury, which informs the patterns that we see on imaging. BTAI is the second leading cause of trauma-related mortality, accounting for 10 to 20% of fatalities. Most BTAI is due to high-velocity motor vehicle collisions. BTAI is more commonly due to frontal collisions than lateral impact collisions. Proposed injury mechanisms include stretch, shear, pinch, and thump effects. What is important to recognize is that aortic injury occurs at points of fixation or tethering, as well as transition sites from mobile to immobile segments. Thus, aortic injury tends to occur at the aortic root, aortic isthmus, and diaphragmatic hiatus. Of these, the isthmus is the most injured site. It is important to know this because it helps direct one's search pattern and alerts the radiologist to an abnormality that could be mistaken for atherosclerosis or artifact. Now, why is the aortic isthmus the most injured site? It's the point of attachment of the ligamentum arteriosum, which tethers the aorta in a rapid deceleration injury. The ligamentum arteriosum is frequently calcified, as shown here. Chest radiographs can be difficult to interpret in the setting of trauma due to technical factors, such as portable supine technique and low lung volumes. We look for certain signs on chest radiograph that are really indirect findings of mediastinal hematoma from the aortic injury. Some typical findings of aortic trauma on chest X-ray that are important to identify include mediastinal widening, rightward tracheal deviation, left mainstem bronchus depression, convexity or loss of the AP window, and a left apical cap, among many other signs. Hemothorax often does not manifest as a meniscus due to the supine positioning, so one might see veil-like increased density of one hemithorax. For a supine chest radiograph, we typically look for mediastinal widening of greater than 8 centimeters, which represents the mediastinal hematoma associated with the traumatic aortic injury. Because the isthmus is most commonly injured, the periaortic hematoma at this location will displace the trachea and left mainstem bronchus by mass effect. The left apical cap represents extrapleural extension of mediastinal hemorrhage over the apex of the left lung. This is because a potential space exists between the aorta and the left lung parietal pleura. Blood from the aortic injury tracks cephalad along the course of the left subclavian artery between the parietal pleura and the extrapleural soft tissues, resulting in an extrapleural apical cap. The veil-like increased density of the left hemithorax is due to layering hemothorax in the supine position. Now we will discuss terminology, classification, and management implications. The distinction between transection and dissection is commonly confused. However, these terms are not interchangeable. This is an example of a Stanford Type B aortic dissection with a dissection flap separating the descending thoracic aorta into a true lumen and a false lumen. A dissection implies a diseased media and the abnormality is propagated longitudinally through the aorta. The definition of transection is somewhat ambiguous. It is used interchangeably with traumatic aortic rupture and near complete or complete tear through all layers. This is where it gets confusing. I think we can all agree that the images on the right can be described as aortic transections, but some may include all as examples of transection. In fact, some papers describe direct signs of transection as pseudoaneurysm, vessel caliber change, or an intimal flap. Because of this ambiguity, and because the term transection may not adequately communicate severity, I favor more descriptive terms. The severity of blunt traumatic aortic injury has been described in several classification systems. The Society for Vascular Surgery classification is based on involvement of the aortic wall. Type 1 injury is an intimal tear, also known as minimal aortic injury. Expected management with serial imaging is recommended for type 1 injury since most heal spontaneously. The Society for Vascular Surgery recommends repair for types 2 through 4, with endovascular repair preferred over open surgical repair. Here are examples of intimal tears. Sometimes the intimal flap may be visible, but sometimes only the associated thrombus is seen. Type 2 injury is intramural hematoma, which manifests as crescentic aortic wall hyperattenuation on non-contrast images and decreased luminal diameter on post-contrast images. Type 3 injury is a pseudoaneurysm with an external contour abnormality. These would be upgraded to type 4 injury if active contrast extravasation were present. Sometimes traumatic aortic injury manifests as a combination of abnormalities. In this case, which has multiple intimal tears and a pseudoaneurysm, the injury grade is determined by the most severe injury. Criticisms of this grading scheme are that the management guidelines are too vague and the timing of repair is not well delineated. Some favor the Harborview classification, which uses morphology of injury to direct management. Instead of grading based on the involvement of the aortic wall layers, the most important distinction to make on imaging is whether an external contour abnormality is present. In general, no external contour abnormality is considered minimal aortic injury and no repair is indicated. An external contour abnormality usually goes to endovascular repair. In addition to the presence of an external contour abnormality, the Harborview classification also takes into account the size of the intimal tear to grade injury as minimal, moderate, or severe. Whether the injury is moderate or severe determines the timing of repair. Semi-elective repair for a pseudoaneurysm without active extravasation occurs within 24 to 72 hours. Severe aortic injury requires emergent repair. In general, these correspond to the Society for Vascular Surgery classifications of types 1 and 2 for minimal, 3 for moderate, and 4 for severe. Here's an example of minimal aortic injury, which is defined as a subcentimeter intimo-medial abnormality without an external contour deformity. Again, these usually resolve spontaneously without treatment. It should be noted, however, that there are no clear guidelines for the frequency and interval of follow-up. If you're having trouble remembering the grades within the classification system, remember that the most important thing is the size of the intimal tear and the presence of an external contour abnormality. Just be descriptive. Now that we've discussed the classification of traumatic aortic injury, let's look at more case examples. I've collected some straightforward and some nuanced cases to illustrate the strengths and ambiguities of the classification systems. This was a 43-year-old man in an ATV accident. We see this large filling defect adherent to the aortic wall at the level of the isthmus. On cine images, the thrombus is quite mobile. While we don't directly see the intimal injury, we see the associated thrombus. So is this an example of minimal aortic injury? The answer is no. Recall that the intimal tear or thrombus must be less than a centimeter to be considered minimal aortic injury. This would be a moderate injury since the thrombus is greater than 1 centimeter even though there is no external contour abnormality. This 44-year-old man was in a motorcycle crash and had these linear filling defects in the descending thoracic aorta. On Cine images, we see that these are mobile intimal tears. This is where the grading gets tricky. By the Society for Vascular Surgery classification, this would be minimal or type 1 aortic injury, but it's more ambiguous on the Harborview classification. One could argue that these intimal tears are greater than 1 centimeter, placing it in the moderate aortic injury category. However, this was treated as minimal aortic injury with no repair. A 38-year-old female had this focal filling defect in the aorta at the level of the diaphragm on axial and oblique sagittal CTA images. This was called minimal aortic injury because of the small size and lack of an external contour abnormality. A follow-up CTA obtained 48 hours later shows that the thrombus has decreased in size. This is a tricky companion case. A 90-year-old woman was rear-ended by a truck at 35 miles per hour. In the distal descending thoracic aorta, there is a triangular filling defect along the anterior wall. On oblique sagittal CTA image, the thoracic aorta is relatively free of atherosclerotic plaque. Because of this and because of the location in the setting of trauma, the possibility of minimal aortic injury was raised. In some cases, it is very difficult to distinguish minimal aortic injury from atherosclerosis in older patients without comparisons. It may be helpful to get a short interval follow-up. This was a 31-year-old male in a high-speed motor vehicle collision with minimal aortic injury at the level of the isthmus, which was treated with expectant management. A follow-up CTA 48 hours later shows that the thrombus has increased in size. It is not well established when and how frequently to get follow-up imaging, and the decision to treat depends on progression and symptoms. This patient did not proceed to TEVAR. Again, it is important to note that atherosclerosis and floating thrombus can have a very similar appearance to traumatic aortic injury with an intimal tear and adherent thrombus. This was a 66-year-old man without a history of trauma who had incidental floating thrombus along the lesser curvature of the aortic arch on a gated CTA of the chest. It looks very similar to the previous case, but we note that there is quite a bit of atherosclerotic plaque throughout the descending thoracic aorta in this patient without a history of trauma. A 14-year-old boy presented after a motor vehicle collision with a large pseudoaneurysm in the proximal descending thoracic aorta and associated mediastinal hematoma. Catheter angiogram again depicts the traumatic pseudoaneurysm, which was subsequently covered by a stent graft. Oblique sagittal CTA images show the traumatic aortic pseudoaneurysm pre and post-TEVAR with successful exclusion of the pseudoaneurysm on the post-repair image. A common diagnostic pitfall is a normal variant at the most commonly injured location. This 69-year-old female was transferred from an outside hospital after a rollover motor vehicle collision due to concern for aortic injury by imaging. On axial and sagittal CTA images, we see a contrast-filled projection along the lesser curvature of the aortic arch, which can be confused for a pseudoaneurysm. However, the presence of a focal calcification alerts us that this is not an acute finding. In fact, we can see that this finding is associated with the attachment of the ligamentum arteriosum. This is a ductus diverticulum or ductus bump. This is an old paper from 1982 that nicely describes the different aortic isthmus types on catheter angiography. A type 1 isthmus is concave. A type 2 isthmus has straightening or mild convexity, and a type 3 isthmus is a focal bulge. It is important to know that these variations exist, but not important to name the types. So how do we distinguish a ductus bump from a traumatic pseudoaneurysm? A ductus bump is a smooth, convex bulge that makes obtuse angles with the aortic wall. A pseudoaneurysm has irregular margins, has a more mushroom cloud appearance, and often has associated mediastinal hematoma. This is another mimic to be aware of. An infundibular origin of a branch vessel, such as a bronchial or intercostal artery, can sometimes be mistaken for a traumatic aortic injury. Sometimes it is hard to distinguish pathology from technique-related artifacts. This was a 57-year-old female who presented after a motor vehicle collision. This focal contour abnormality along the anterior wall of the ascending aorta was noticed on a non-gated CTA of the chest. Also note the sternal fracture. The ascending aortic abnormality persisted on an ECG-gated CTA of the chest and was treated as a traumatic pseudoaneurysm. The patient went on to open surgical repair with ascending aortic graft replacement. Now, should we always raise concern for traumatic aortic injury when we see a mediastinal hematoma? The answer is no. Sometimes the mediastinal hematoma is due to a venous bleed, and preservation of the fat plane between the hematoma and the aorta is reassuring. This patient was in a motor vehicle accident with significant injuries, including bowel injury requiring a colostomy. On axial CTA images, the aorta just above the bifurcation has an apparent intimal flap that could be mistaken for a dissection. On coronal images, the intimal tears and associated external contour abnormality of this traumatic pseudoaneurysm are easier to appreciate. This was a 50-year-old female who presented after a 50-foot fall. There is some controversy over whether this external contour abnormality was a ductus bump or a traumatic pseudoaneurysm. Note the irregular margins and greater than 180-degree involvement of the aortic diameter. Also, there are two irregular bulges along the lesser curvature of the arch. We have not seen a ductus variant that looks anything like this. The patient went on to get a follow-up CTA a few days later that showed the two bulges persisted and slightly increased in size. She went on to endovascular repair. The guidelines do not distinguish between small and large pseudoaneurysm treatment recommendations, although an emerging concept is that some small pseudoaneurysms might be amenable to non-operative management. This is another challenging case. A 21-year-old male sustained significant injury from a motor vehicle collision, and this small contour abnormality was identified at the aortic isthmus on initial CT. He went on to get serial imaging due to other complications from polytrauma. On the next CT, we see that there is larger endoluminal thrombus associated with an intimal tear, but we no longer see the external contour abnormality. This was downgraded to a minimal aortic injury. A follow-up CT had similar findings. On the last CT, we now see that the thrombus has resolved, but the original contour abnormality has increased in size when compared to the initial CT. This case highlights the fact that aortic trauma does not get downgraded. The pseudoaneurysm was obscured by adherent clot but persisted. This patient went on to endovascular repair. Now we've seen several examples of repaired traumatic aortic injury. Let's review the normal appearance and complications. Following endovascular repair, we should see that the endograft is well opposed to the aortic wall at its landing zone. The pseudoaneurysm should be excluded with no residual contrast opacification. Sometimes it may seem like the left subclavian artery is covered by the stent graft in order to obtain an appropriate proximal landing zone. On this follow-up CTA, antegrade perfusion of the left subclavian artery is preserved. This is because the end of the endograft is uncovered for a short segment. Here is an example of left subclavian artery coverage. This patient had multiple traumatic aortic pseudoaneurysms, including one that began just distal to the left subclavian artery takeoff. In order to exclude the pseudoaneurysms, the left subclavian artery was partially covered. On the completion angiogram, we see poor antegrade perfusion of the left subclavian artery with retrograde filling. Now, in follow-up CTA, there is resultant thrombus in the proximal left subclavian artery. Is this something to be concerned about? Most patients tolerate left subclavian artery occlusion without consequence. For example, in this case, the thrombus resolved on follow-up imaging. It is still important to mention left subclavian artery partial or complete occlusion if present. Complications may include stroke, paraplegia, left upper extremity claudication, and subclavian steal syndrome, since the left subclavian artery supplies the left upper extremity and left vertebral artery. Selective revascularization depends on the vertebral artery anatomy, such as an atretic or hypoplastic right vertebral artery without an intact circle of Willis. Here is a case in which the arch anatomy and coverage of the superarch vessels were important. This patient had a bovine arch with a traumatic aortic pseudoaneurysm in the proximal descending thoracic aorta. Endograft covers the origin of the left subclavian artery and even extends into the common trunk of the brachiocephalic and left common carotid arteries. A few days later, the patient developed left homonymous hemianopsia and was found to have a right PCA territory infarct with corresponding signal abnormality on this axial diffusion-weighted image of the brain. An endovascular approach was taken to revascularization of the left subclavian artery with a single side branch and a chimney bridging the brachiocephalic left common carotid artery trunk. Other complications include endograft infection. This was a patient with a history of traumatic aortic injury 5 years prior to presentation with chest pain, fevers, and dysphagia. On axial CTA images, there are locules of gas and phlegmonous changes surrounding the endograft with mediastinal lymphadenopathy. A subsequent PET CT shows increased FDG uptake in the region of periaortic phlegmon. This patient proceeded to open repair and stent-graft explantation. Other complications include endoleak, stent-graft migration, and stent-graft collapse. Although these complications are relatively rare and endovascular repair is usually well tolerated. We have reviewed blunt traumatic aortic injury mechanism, classification, management, and post-repair follow-up. The aorta is most commonly injured at the isthmus due to the attachment of the ligamentum arteriosum acting as a point of tethering. This is an important place to closely inspect when looking for traumatic aortic injury. Remember that the underlying pathology is different for traumatic aortic injury and dissection, and transection and dissection are not equivalent. Since the morphology of the abnormality determines the necessity and timing of repair, it is important to be descriptive. The report should communicate the presence of an external contour abnormality and the size of the intimal tear or thrombus if present. Thank you for your attention. Like and subscribe for more videos and comment down below what topics you'd like us to cover.